Hello, my name is Shavana Jonathan. This is my case study for Clinical Rotation 1 of RTE 1804 for Kaiser University. My case study today is about a periprosthetic distal femoral fracture. Through this case study, we will be discussing the patient history, images, positioning and technical factors, image findings, the procedure that was necessary for the patient, my conclusion, and the references. So this patient was a 67-year-old female who presented to the ED as a trauma case of the left lower extremity. She slipped on water on the floor and fell onto her left knee. She reported her pain to be an 8 to 9 on the pain scale when she was in the room. She had a recent left total knee replacement done 6 months prior. And because of the fracture that happened, she underwent the ORIF procedure and was prescribed physical therapy afterwards. She was eventually discharged with orders to bear weight as tolerated. So there were multiple rounds of x-rays that were done on this patient. This first round of x-rays will be the ED images that were ordered. They were a 4-view left knee study. The 4 views were AP, internal and external oblique, and lateral. The images were taken while the patient was recumbent in the stretcher. Due to the pain, the left leg was treated as immobilized, and a 14x17 IR was used for all images. So for the first view, that was the AP knee. So as far as positioning goes, the patient was supine because they were already recumbent in the stretcher. So the knee, we did not have to physically move or accommodate the knee in that sense. What we had to do was angle the tube 5 degrees cephalad. The technical factors used were 70 kVp and 3 mass. In the AP view, you can see the distal femur right here. You can see the total knee replacement as well as the proximal tib and fib. Here you can see the actual fracture. So when she fell on her knee, this is how the fracture came out. And again, this is the left knee right here. So we do have a little bit of whiteness up here, but again, the main focus is this area right here, right above the knee. And so with the factors used, the pathology is clearly visible. For the next view that we had, it was a lateral knee. Because of the state of her pain and the state of her fracture, we could not get her to turn or to lean, put any kind of weight on that side. So we had to do a cross table lateral, which means that the patient was supine, but what we did was place the IR on the lateral side of her knee and shoot through the medial side of her knee. So the tube was on the medial side perpendicular to the knee, and that's how the image was captured. To get her knee to be visible within the IR, it was propped up with a blanket, which helps to keep the knee from being too low on the IR. So the cross table lateral really allows for a very clear view of the fracture and just how deep within the bone it is. And you can see that there is quite a bit of space between the fracture. And so you can see here we also have, again, the distal femur, the knee replacement, patella. We do have tib fib here as well. For the internal oblique, the patient again was supine, so we could not get her to rotate in any direction. So what we had to do was angle the tube 45 degrees medially and have the tube compensate for her lack of rotation. The knee was kept in the AP position, and the technical factors used was 70 kVp and 3 mass. So here the fracture is right here, but it is not as visible, but this was part of the exam that they ordered, so it was done regardless. And here we have the whole knee replacement, again, distal femur, proximal tib fib, and the fracture right in this area right here. For the external oblique knee, you can see the fracture as well here. So the AP, the cross table lateral, the external oblique, the fracture is very visible. For this, again, the patient could not rotate, could not move, nothing like that. So we kept the patient supine, we kept that leg in the AP position, kept that knee in the AP position. The technical factors used was 70 kVp and 3 mass. So for kind of like the medial oblique, but the tube was angled 45 degrees laterally while the knee was kept in the AP position. Once those studies were sent to the radiologist report deemed that the patient was found to have an acute periprosthetic fracture of the distal femoral metaphysis with slight interval improved alignment of fracture fragments and no dislocation. So as we saw in previous images, the bone was still together, which is why there was no dislocation. Periprosthetic fracture, meaning that it is near a prosthesis, such as the total knee replacement. When they're saying distal femoral diaphysis, they're just talking about distal femur in the area between the metaphysis, in that kind of fusion area of we're getting lower in the diaphysis coming into the metaphysis of the long bone of the femur. So once those images came back, they gave the patient a splint, and then they ordered a 2-view knee study. So these outer ridges right here, this is the splint. We're starting with the AP image right here. Again, we kept the patient supine. It was an AP knee, so we angled 5 degrees cephalad with the tube. The technical factors used were 70 kVp and 4 mass, 14 by 17 IR for every image taken. And again, here is the fracture right here. Like I said, this is the splint, and you can see a little bit of texture throughout the image, and that is just because of the splint. So it looks a little rough, but that's just from the splint. The fracture is still visible. Distal femur, proximal tib fib is still visible. Contrast is enough to see the fracture right here. For the lateral of the splint image, they did another cross table lateral. And again, we can see the fracture right here. We have our proximal femur. We have our distal femur. We have our proximal tib fib. And for this, again, the patient was supine. The technical factors used 70 kVp and 3.2 mass, as we can see right here, and 400 MA. And the IR was, again, because it was cross table, IR was placed on the lateral side of the knee, the tube was placed on the medial side of the knee, and then just perpendicularly shot through. The knee was again propped with a blanket, as well as you can prop with a splint. So we had to kind of prop the whole splint up with the blanket. 14 by 17 IR. We do have that ridge from the splint here and here at the borders, and it does contribute to this, again, texture of the image. Like, it looks very kind of bumpy, but we can still see the pathology clearly. We have our patella, we have our total knee replacement, so everything that the doctor was looking for was present in the image. So the procedure that was done is something called an ORIF. ORIF stands for open reduction and internal fixation. In this situation, once the site was open, they used clamps, traction, and close reduction techniques to help reduce the fracture. They also wrapped a Luke wire around the fracture site, and a 14-inch femoral nail was placed into the medullary cavity with 4 interlocking screws distally and 2 screws proximally. The surgeon then used 2 reconstruction plates to secure the fixation, for secure fixation, to make sure that everything is in place where it needs to be and nothing is going to come loose, nothing is going to become a problem later on. A xenograft or a non-human implant was also used to manage the dead space within the surgical site. Antibiotics were given, everything else was closed up. The surgeon did use fluoroscopic images to ensure proper location of all devices. Here we have some of the images that were used during fluoroscopy in the ORIF. From left to right on the top, we have the first image of just the total knee replacement. In the second image, we have the femoral nail that was placed in to make sure it's in the medullary cavity and how far down it needs to go within the medullary cavity. The third image we have is the reconstruction plates with the distal screws interlocking. And the fourth image down, the fourth image shows is just another view of the rod with the reconstruction plates and the interlocking screws. In the fifth image, we have the proximal femur with the two anterior locking screws. And then on the last image, we have the loop wire, we have the reconstruction plates, the distal femoral screws, and just that kind of lateral view to see how everything's looking in there. So for the post-op images that were ordered, they wanted AP and lateral of the proximal and distal femur, and for collimation to also include the knee, which is normal for a distal femur. 14 by 17 IR used for all images, and they did post-op images to make sure that the devices remained in place correctly with no new complications. Now for the AP proximal femur, they were looking to see the placement of the rod and where the placement of the rod starts. The patient was supine. The technical factors used were 70 kVp and form mass, and the CR was centered to the proximal thigh. And we can see here that it is a little mottled, but because they were really just focused on the placement of the rod, it is visible for that purpose. For the AP distal femur, again, they are looking at device placement. The patient was supine. The technical factors used was 70 kVp and form mass. CR centered to the mid-thigh, collimated to include the knee. And this one there's a lot more black that is seen in this picture. So the contrast is a little more distinct, and that allows us to see the devices that gives us better clarity of the devices. For the post-op laterals, they were done cross-table because, again, this patient was fresh out of post-op, and it's, again, under general anesthesia, things like that, it's very hard to get a patient to move, and you wouldn't want to risk that, especially if they're just fresh out of post-op. This was done as a cross-table lateral, and a cross-table lateral was done the same way, IR on the lateral side to shooting through the medial side. Technical factors used, 75 kVp with form mass, CR centered to the proximal thigh. For the lateral distal femur, again, cross-table lateral, 70 kVp for mass used, CR centered to the mid-thigh, collimated to include the knee. And again, this picture has a lot less shades of gray, so the contrast is better. We can see the devices in much better clarity. In conclusion, falls are the most frequent injury among geriatric adults. Among geriatric women, common causes of falls are incontinence and frailty. Distal femur ORIF procedures place geriatric patients at a high risk for poor 30-day post-op outcomes. This is typically related to geriatric patients 80 years and older. Typical risks are mortality, non-home discharge, and surgical complications. Due to the nature of this patient's injury and the level of care needed to remedy the fracture, radiographs played a fundamental role in her path to recovery. With appropriate techniques and careful patient handling, diagnostic-based significant images were produced, allowing the radiologist, ER doctor, and orthopedic surgeon to provide the care necessary to repair the fracture. Thank you for viewing my case study.